So hi, I apologize. So I was waiting for that like bolt of lightning. So and boom, it just hit me. So welcome everybody. We're glad to have you join us today. And we are going to be discussing how can I go back to home safely and what you need to know about being discharged from the hospital, ... Of course, during these challenging times. I mean, being discharged happens, you know, in our challenging times and not. Of course, we have that extra ingredient today. So we have a wonderful panel that we're welcoming today to discuss this. You know, just a little bit of housekeeping. First of all, we're going to be doing questions at the end. So if you have questions, you can submit them. We'll be fielding them when, you know, after our last speaker. And I believe we're on meeting format, so everybody can, you know, look at each other, you know, during the course of this discussion. And we're sure that you'll get a lot of information, timely, pertinent, and helpful for you in this specific topic. So why don't we get started with our first speaker. Our first speaker is Lucille Hughes. Lucille, as I find your bio, I'm sitting here, okay. Lucille Hughes is the service line administrator for digestive health and endocrinology from Mount Sinai, South Nassau, located in Oceanside, New York. She has extensive experience in outpatient program management, as well as inpatient diabetes policy, care, education, and management. She is board certified in advanced diabetes management and a fellow and board member for the Association of Diabetes Care and Education Specialists. Dr. Hughes is an adjunct professor at Delphi University, teaching in the College of Nursing and Public Health. Dr. Hughes is also the president and CEO of Creative Teamwork Services, LLC, specializing in improving organizational teamwork, leadership, and communication skills. Help me welcome here today, Lucille.
Thank you, Vicki. Can everyone hear me?
Hear you well.
Okay, great. We're just waiting for the slides, and here they go. Thank you so much, Jackie. So welcome to everyone. I'm thrilled to be a part of today's presentation, and I will be discussing, as we mentioned, preparing for discharge and making it a safe reentry to home. So we'll start with advancing the slide to our first slide, and we will start at the beginning. Jackie, next slide, please. There we go. Wonderful. So starting at the beginning, I'm sure if you're like me, we remember that wonderful quote from Jerry Maguire, "You had me at hello." Well, that holds true for admissions as well and discharge planning. From the patient's perspective, you had me at hello. From the minute I walk in that door to a hospital, we should be beginning our discussion about returning me home safely. From the perspective of the professional, we need to capture every moment with that patient. And again, on admission, when we're doing our admission assessment, we want to already start thinking about discharge planning. Unfortunately, what happens in many healthcare facilities is we get notice the patient is leaving at 3 o'clock and it's 2 o'clock in the afternoon. And now we're scrambling to get services, the education done, and that doesn't serve anybody well. It doesn't serve the patient, their family, or their providers. So I can't stress enough that discharge planning really needs to start at hello. And our discharge goals are always very, very important. Safe reentry to home. Safety is our #1 priority for all of our patients. We want them to continue the journey to health and wellness that hopefully we started and did so well in the healthcare facility. And we want to prevent readmission, especially within the first 30 days. That's sometimes tagged as something that no healthcare facility really wants as far as their record is concerned. Now, we all know sometimes it's unavoidable. It could be not related to their previous admission. It could be a fall. It could be an injury in some way. but we really don't want to have a readmission within 30 days from the same incident that brought the patient into the hospital initially. So let's look at who should be present during that discharge planning conversation and ongoing conversations. This is at every interaction with the patient, always talking about returning to home or returning to what I call that stop off if there needs to be a place prior to home. So the staff needs to be involved. The staff, we have to understand too, and oh, not yet. Can we just go back one slide? There we go. I'm just on number 3. Thank you. So with our staff and family, we have to realize too that the hospital situation or environment of care, we all know it's not a hotel, right? People don't really want to be there. And when they are there, the stress level is incredibly high. Now, if we could just think of our own experiences when we feel stressed, even the simplest things or tasks are hard to complete because our stress level just prevents us from making just simple thoughts. So we want the staff, every staff member that could have any positive input into that discharge planning, whether it be the physician, the nurse, the pharmacist, possibly physical therapy, home care representative, care coordination team. Some facilities have different names for these providers, but as many as possible to really fill in that picture of what that transition is going to look like. And you'll hear me say more than once today that the patient doesn't know what they don't know. Okay, you'll see that actually in the next slide or so. So we need to be on task and proactive to help the patient and the family establish and secure everything they need in that home environment. So family members, we're talking about COVID. What happened during COVID now is we've limited drastically the amount of family members that can be with the patient. Luckily now you're allowed to have somebody with you, but go back a month ago, that patient was alone. So we do have technology that helps us right now at the hospital. I know Mount Sinai, South Nassau, we make sure that our patients are connected via iPads and other technological tools to their family or loved ones or friends that can help be that extra pair of ears for that patient and to answer some questions that might be needed to ensure that safe reentry to home. When we look at number 4, the environment of care, we want to look at how that patient will be able to function at home. Look at what they were doing beforehand and how that's going to happen in that home environment. And our next speaker, Jangir, will also touch on that in greater detail. We want to look at, will they need help? And who will that help be? Will they need someone for 2 hours, 4 hours, maybe 24 hours a day? That all needs to be assessed beforehand so we can make those arrangements prior to discharge. What equipment will they need? Thinking about their disease or condition in the hospital. Their equipment could be something as simple as, will they need a wheelchair, a walker, a bathroom assistance, right, commode, a different bed. If they're in a wheelchair, will they have access? Will they be able to go through the door frame of that bathroom or into the kitchen and reach what they need to? So many things need to be thought about ahead of time for, again, placing that patient back in their home environment. And then lastly, can the home environment accommodate for all the patient's needs? And that's where we start thinking about door frames, but it could be as simple as, are there throw rugs? I happen to have a lot of throw rugs in my house. If I had a fall or there's a potential for fall, if I'm at high risk for a fall, they all need to be removed before I get home. They're not going to work well with walkers. And we want to remove those items, simple things. People sometimes don't think about it, but we want to remove them before that patient re-enters home. Extension cords. I cannot tell you how many people, unfortunately, will trip on extension cords, or now we're dealing with portable air conditioners, and in the wintertime, portable heaters. So we have to look at that environment of care. You know, we always talk about muscle memory, but we have vision and brain memory. So we know our environment of our home. We could probably walk through our home blindfolded, although I would not recommend anyone doing that. But when we put different objects out that aren't usually there, they tend to be the objects we're going to trip over. So next slide, please. Staff directives. So this is now from the perspective of the staff that's in that healthcare facility talking to the patient. For me, as an educator, nurse educator for close to 36 years now, I believe very strongly and passionately that education is the key to success in every aspect of healthcare. So we want to make sure that that patient has access to patient education. And once again, that starts on admission. An example for you is if that patient, let's say, has diabetes and they are on insulin. Most hospitals use insulin syringes. The patient will most likely go home with a prescription for an insulin pen. So we want to make sure that that patient can practice using a pen. Usually it will just have water in it and they're not injecting it into their body, but a pretend abdomen. But we want to see them use those skills and have the understanding and knowledge of how to use that piece of equipment, because what happens, and this is what happens in real life, is the patient goes home, they pick up their prescription, they say, what is this? I've never used this before. I don't know how to put the things together. And I will tell you 2 instances that are real situations. Patient came in, blood sugar very, very high. We asked the patient, were you taking your insulin? They said yes. We said, could you please show us how you're using your insulin pen? The patient was squirting the insulin into his mouth with the needle, squirting it into his mouth and swallowing it. And we said, why would you be doing that? They said, well, I got insulin injections in the hospital. I was on pills before I got here, so that was somewhere in the middle for me. And that's what this person came up with. And obviously, insulin doesn't work when you digest it. Another person was taught on injecting into an orange. So they continued to do that and ate the orange after they injected it with insulin, thinking that was going to help them. So we cannot stress enough that patients need to practice skills, whether it's a colostomy, an ileostomy, insulin injections, anything needs to be practiced in the healthcare environment. Educating the family, again, extra pair of eyes and ears to support that patient when they're home. If you've ever been a patient, you know you've been bombarded with many, many providers walking into your room constantly and being told many different things. You can get confused at home. And you also walk away with a booklet of papers. And you have to decipher that all when you get home as well. So we want to make sure, number 3, that the patient has their supplies. If they're going home with an insulin pen, they need the needles as well. Many times that doesn't happen. They pick up the pen, but the needles were never prescribed. That's not going to help the patient. So again, practice the skills and tools, and that lead time, starting this on admission, that education, not the hour before the patient leaves, is going to be optimum. Okay, next slide, please. Patient directives. So now I'm going to speak on the perspective of the patient. Our campaign at Mount Sinai South Nassau, and I know it's shared with many healthcare institutions today, is do not put your health up. Can you just go back ahead of me? Okay. One more. There we go. So patient directives. We don't want you to put your health on hold. So what that means is asking as many questions as possible. Again, you don't know what you don't know. So there's no question that is too silly, too unimportant. They're all important if you don't know the answer to them. So we want you to ask questions. And when I was practicing in the hospital, I always left a pad and a pen next to my patients to say, you're going to think of something really important as soon as I leave. I know that's going to happen. So write it down so you don't forget it. And next time I come in, we can address your questions. And that's a great practice to get into when you're going to your physician in the outpatient environment as well. You want to know things like, when do I call? What's important? When something gets red, when I have a fever, when I have a cough, what are the criteria for making that call to my provider? And who do I call? Which provider? Because sometimes, let's be honest, when we're patients leaving the hospital, they may have a primary care physician, they may have a gastroenterologist, they may have a physical therapist. Who am I supposed to call when something happens? So that should be discussed ahead of time. And what numbers? What numbers will lead me to that person that I need to speak to in that emergency? And again, what's the criteria for an urgent emergent call? And when do I go back to the emergency room? Where can I find additional resources? We offer things like support groups, furthering my education if I was a patient. I've learned so much here in the hospital, thank you so much, but I need to be my own advocate. I need to be self-sufficient in my care, whether it's my disease or my condition. Where can I learn more about this? And again, the internet is wonderful, but be very mindful of where you're getting your information from. Chat rooms can be a little bit scary because you don't know. Anyone can say they are a professional, so you want to be mindful. Not all chat rooms are being monitored. So make sure you go into a reputable site if you choose to read things on the internet. And things like rehab. What's the best rehab? Do I need to go to a rehab? A stop-off was what I call before I return to home. Next slide, please. So again, our initiative, our campaign is Don't Put Your Health on Hold. With COVID, everyone was afraid to go to the hospital, and understandably so. If I go back 6 weeks, we only had maybe 1% of the patients in the hospital did not have COVID. Things are very, very different today. We have at the very most like 3 patients in the hospital. And I'm going to be honest with you, I don't know if there has been a safer time to go into a hospital because we are so careful. We are so mindful of infection control procedures than ever before. So we want every patient in the community to feel that they can come to the emergency room and seek health care if they need to. It is very safe to do so. But you want to be your best advocate for yourself, knowing your meds and name, not the color. So obviously this is a pet peeve that's coming out from, again, my many, many years in nursing. This happens probably once a week. I'll do what we call a med reconciliation, where we want to make sure we know all the medications you're taking. We want that list to be accurate and relevant and up to date. Excuse me. So when we ask you what medications you're taking, you tell us the little blue pill or that round yellow one. That doesn't help us and it doesn't help you because there are medications that have very, very adverse effects to other medications you're taking, or maybe a treatment that we're going to give you. So for instance, if you're taking metformin for your diabetes, we need to know that because we cannot give you a procedure that's going to inject you with dye unless you're off of that, and we keep you off of it for 48 hours. So all medications are very important to us, including your over-the-counter medications such as vitamins. So make sure you tell us everything. Something benign as a vitamin E is a blood thinner. And if we're going to prescribe one for you, we're going to need to know that you're on that. So have a list with you. Make sure it's up to date. Make sure that list includes your medical history and dates. You are not going to remember these things in a high-stress situation. And include food allergies. They are as important as your medication allergies. Bring your legal health care related forms with you. And Ron will be speaking about that shortly, how important that is. Bring your phone charger. I put this in here specifically because now during COVID, we realized you can't just ask somebody to bring it, and whether your phone is charged now, it won't be 12 hours from now. And if you think you remember the name and phone number of your loved ones, you're going to forget them if you do speed dial all the time and under stress. So it's very important that you keep that phone charged with you and a backup list so we can call your loved ones and get additional information if you don't have that for us. Next slide, please. So who's driving the bus and who are you bringing with you? I'll end with this slide because, again, as a nurse educator, it's really important that in our work as healthcare providers, that we provide our patients with as much education and self-directed care that we possibly can. We want our patients to self-manage their care. So that means we need to give them the skills, the tools, and the knowledge to drive the bus. But we want to come on board with you. We want to be, as your nurse, I want to be there for you. as a guide and a provider, your doctor, again, pharmacist, exercise physiologist, your home care team. We all want to be on board, your diabetes care and education specialist, but we don't want to drive. We want you to drive, and you to drive a very long and healthy life to health and wellness. That's a job well done from the provider side. Thank you so much for your time. I will now hand it over to Vicki to introduce our next speaker.
Thank you very much. That was so excellent, Lucille. I just have a quick question. During COVID, when there's this, certainly we're at a disadvantage in the discharge process, that somebody may not have somebody there, to hear what's going on. I mean, that's the ideal, right? Say to the patient,
yes,
to somebody else. So how is that being addressed at this point? Can you give us some pointers on that?
Oh, absolutely. We have wonderful technology today. So we bring the family to the bedside with iPads. So everyone is there listening to whatever that patient is listening to or hearing. We bring the family to the bedside with technology. And I will say it's not just Mount Sinai South NASA. All hospitals are using this technology. So the patient is never really truly alone, physically maybe, but with technology, we can bring everyone to the bedside.
That's great. And just one other pointer, because and I'm a nurse also, so I hear the charge and the call for it. When we talk about people researching things in reputable sites, what is a reputable site to you? What would you make a recommendation for that?
Oh, certainly. So if you're going to, I will use, for instance, diabetes as one. If you go to the American Diabetes Association, or the American Association of Diabetes Care and Education Specialists, those sites have to be research-based, which means that there's evidence behind anything that's on those sites. That's very different than, again, a chat room. And I've had personal experience with patients that unfortunately received very poor information that led to poor outcomes by listening to someone in a chat room. So we want to be mindful of that. But if you go to an association website, whatever the condition is that you're looking for, you could be well assured that it is based on evidence.
That's great. Thank you very much. We appreciate this information. And I know that you're very passionate about community and professional education, which is you demonstrated in your presentation today. Thank you very much.
My pleasure.
For being a panelist today. We really appreciate this information. Thank you so much. So moving into our next speaker. Our next speaker is Jahangir Sultan. And I just mentioned something about passion, and I think that all of our speakers, that's kind of like a common thread, because they all have distinct passions relevant to their field. In Jahangir's case, the experience he had in helping care for his grandparents ignited his passion to pursue a career related to elder care, and so that's what brings him to the healthcare industry that he has, and being the founder of Patient Advocates of New York. So we want to welcome him here today. And as I said, he's the founder and CEO of Patient Advocates of New York. He was born in Brooklyn, New York, and raised in England. And as a child, I thought this was so interesting. When Jahangir sought more information about his heritage, his dad sent him to live with his grandparents in the Himalayas at the age of 10. And that's where he got that passion about helping and thinking about care for the elderly population. And he's worked in various healthcare settings and in roles such as occupational therapy manager, regional manager of rehabilitation, and director of specialty programs. One theme that has remained consistent in his focus on providing his clients with the best care possible. Hence, he created Patient Advocates of New York with the mission of changing healthcare from what it is to what it should be. So welcome, Jahangir. We're looking forward to your presentation.
Thank you, Vicki, for that beautiful introduction. I want to take this time to thank Ron and Jackie for setting up this venue so we could meet together today. I'm going to share my slides. Are you able to see my slides?
Yep.
Great. Okay. As Vicky mentioned, I'm the founder of Patient Advocates of New York. We're a care management company here in New York. And today we're going to talk about safe discharge planning from the hospital. So when you're planning for a discharge from the hospital, there are multiple people involved in your care. So there's the medical department, the nursing department, the nutrition department, rehab department, social work, and recreation. So I'm going to just go through each department and go through the expectations that we should plan for before discharging from the hospital. So in regards to the medical department, you're going to have an attending who's going to be responsible for your care. You also have a resident who's involved in your care. What we encourage our clients to do is to meet with the attending prior to 1 week before their discharge. The residents are, they're basically students learning about the field of medicine. Some are really great. And some are brand new to the field, especially during the time of summer. We have a lot of new medical students going into the hospitals. So what I always encourage my client is to meet with the attending just to make sure that we crossed all our T's, dotted all our I's, and everything is in place. So they meet with them, they just go through all their concerns, make sure that they're being addressed. I also encourage them during that time to find out if they're going to make some referrals for some providers in the community. So what I encourage my client to do is to find out if these individuals are in-network, out-network, plan for that. Also, sometimes people make referrals to clinicians, and you want to make sure that they are going to meet your specific clinical needs. So you want to research and find out the person that's being referred to you, if they are, basically competent enough to take care of you. You also want to factor in their personality. Is this somebody that you feel comfortable sharing your problems with? And you can do that research, or you could have your loved ones do that research for you as well. Another factor you want to look at is their operations. In this age of COVID, we have a lot of providers that are doing remote visits or televisits or FaceTiming. Is that something that you value? Will you feel comfortable from those type of visits? Or would you like an in-person visit? Is this referred provider, are they going to be able to provide that for you? And that's something you want to look into as well. Your primary provider is also going to determine your discharge date, so you want to discuss that. You also want to make sure all your prescriptions for all the various disciplines are signed by the providers, because sometimes what happens is that you're provided with a stack of prescriptions and one prescription is not signed, and just the process of getting that prescription signed becomes tedious. So just keep that in mind. So another department that you, of course, will be working with is the nutrition department. They might recommend a low-calorie diet or a low-sodium diet. Whatever that diet may be, you want to make sure that you have that set up in home. So you want to make sure you have the food in place. If somebody has to go out and purchase that for you, you want to have that in place. They might recommend a meal delivery service. So you want to get that the number for the meal delivery service and make sure the date of discharge that it's set up that you're going to have a meal prepared and ready for you when you get home. Another area that we're going to look at is the rehab department. And the rehab department consists of the occupational therapy department, the physical therapy department, and the speech language pathology department. And so when it comes to the occupational therapy department, they are going to provide you with a home exercise program. Make sure you review that program with your therapist. Make sure you understand that program. If you have difficulty remembering how to perform your home exercise program, have your family member go over that exercise with your therapist so that you feel comfortable, that they feel comfortable doing that exercise with you. Sometimes therapists recommend specialized equipment such as TheraBands, Theraputty. if they're not going to provide you that upon discharge, just make sure you order that the equipment before you're about to go home. I know Lucille talked about home safety evaluations. I think that's so important. Usually the occupational therapist does the home safety evaluation, and just take the time, sit down with your therapist and go through your home environment. If you get measurements of doorways, that would be great. That will actually improve the safety in the home. But you want to basically have them do a walkthrough your place before you go home. Durable medical equipment is so important. I had a client who had a hip replacement, and they needed a raised toilet seat, and they were discharged home. And unfortunately, they ended up coming back to the hospital because the raised toilet seat wasn't in place, and they ended up using the regular restroom and popping their hip, and they ended up back. So if your occupational therapist is recommending specialized equipment, you definitely want to have that approved by your insurance and set up at home, or have it delivered to the facility where you're basically going to end up taking it home on the date of discharge. The other thing that you should consider, sometimes the durable medical equipment needs to be modified, and you want to make sure that it's modified to the appropriate height, that it's meeting your needs. Sometimes occupational therapists make referrals for outpatient clinic, or make a home care referral for occupational therapy, and you want to make sure that the clinical background of the therapist matches the needs of your client. So now going over to the physical therapy department, same thing with your home exercise program, your home exercise equipment, outpatient PT, home care. You want to make sure that they're meeting your needs. And with the physical therapists, they're going to make some recommendations for ambulatory devices. Now, if you are not going home in a wheelchair and you're planning to ambulate to the car, you want to make sure that you have a rolling walker, a string cane, or a narrow base quad cane, or a rollator. You want to make sure that you have that in place before you leave the hospital. You never, especially after they've made that recommendation, if you don't have these ambulatory devices in place and you're walking with that, you're at high risk for falling. So you want to make sure you have that in place. Now, some of your patients or clients might need speech language pathology services. So same thing with them. They'll provide you with a home exercise program. Make sure you go over that exercise and have a good understanding of it. They might recommend a certain food consistencies for you, puree, chopped. So with food consistency, let's say if they recommend a puree diet, you want to make sure that you have a blender at home that can puree your food for you. They might recommend thicket. With a lot of hospitals, they actually provide you with a supply of thicket before you go home. But make sure you order enough thicket at home, because you're going to want to drink water, especially during the summer. So you want to have a steady supply of thicket before you go home. Sometimes a speech therapist might put you on some type of aspiration precautions, and you want to make sure those aspiration precautions are somewhere visible. So if you're getting home care services, that they're aware of these precautions. Again, they might also recommend outpatient speech therapy, a home care referral, and the speech therapist that you're going to encounter, you want to make sure that they meet the needs, your clinical needs. They also might recommend an alternative communication device, and you want to make sure that you're able to use it, and also somebody who's going to be involved in your direct care is also able to utilize the device. Transportation. Now, this is a big thing as well. So when you're looking at transportation, and let's say if you're having difficulty getting in and out of the wheelchair, you want to make sure that you have an ambulette in place for you. So the ambulette can basically accommodate a wheelchair and bring you home. Sometimes what happens is a client is really dependent in wheelchairs, and they're sent home in the car. In the process of them transferring from the wheelchair into the car, they have a fall right there in the hospital, and then they end up right back into the hospital. So you always want to make sure the appropriate transportation has been put in place. Of course, if you have a much more medically complex situation, you're stabilized, but you're still medically complex, you might need an ambulance to transport you home. And your social worker, which plays a large role in your discharge planning, is going to make sure that the proper transportation is in place. You want to review your discharge plan with your social worker. They're going to make some referrals from mental health providers. Again, you want to make sure that they are in your network. And if they're not in your network and you really want that provider, you want to make sure that it's the co-payment is going to be something that you can afford. They also might make community-based referrals for other services to help you basically get reintegrated into the community again. Now, recreation. Recreation is so important as well. You might have somebody who stops by, and they're a great resource. So let's say if you are a person that engages in yoga, Pilates, weight training, dancing, they will help you to factor in your new precautions that you might have in place and help you to modify some of the activities that you're engaging in. And so that's something to consider as well. Insurance, of course, is a big factor in discharge planning. So you want to make sure that, all the referrals that are made to you, that you find out if they're in network, out of network. Prior approvals are so important. Your doctor may recommend 5 hours of home health aid services, and you want to basically make sure that your insurance is aware of that, and are they agreeing to provide those 5 hours of home care services. And how you do that is by basically getting a prior approval. Now, sometimes they might say, well, we don't feel like you need 5 hours of home care services. And at that point, while you're in the hospital, the social worker can advocate based on the team's recommendation that you basically need those 5 hours to make sure that it's a safe discharge. But if they don't, and they're recommending 3 hours, that might change the discharge plan. So this is a great time for everything to get reconciled so that you have a discharge plan. It's also important, if you are the person that's engaging with the insurance company or your social worker, that you're getting authorization numbers. You want to make sure that they're documenting the time, the individual they spoke to, and the authorization for each conversation that you're having with the insurance company. So we're always on the same page with them. Now, grooming, I feel, is a big, important thing to factor in as well. So the best way to kind of re-emerge into the community again is to have some personal care services in place as well. I had a cancer patient. She finished chemo. She had in the hospital, and we were transitioning her over to the community. But she basically had given up, and so I, with her family's permission, I was able, and this was of course before COVID, I was able to set up, have a hairstylist go in and help her with her hair, a makeup artist to come in, and just on their date of discharge, make her feel really good about herself. And I have to tell you, that was, I'm so glad that I put those services in place for her, because it helped her to think about, transitioning out of the hospital environment into the community. And she was more anxious to go finally home. And it actually helped me when I was continuing to help her with her care in the community to just, it changed her whole feeling about moving from a hospital environment into the community and having something to look forward to. Lucille, I know, touched on nursing. With nursing, again, going over the home care hours is so important. Going over the medication list and reconciling that with your community pharmacy is so important, because there's some of the medications your doctor might have removed and some have been added on. You want to make sure everything is reconciled before you go into the community. And that's it. Thank you.
Thank you, Jangir. That's very comprehensive. Just as a point of reference, and for general understanding, we're talking about the perspective of the discharge from hospital, and then people are going back to the community. Would you agree that there are services that can be implemented, beyond what somebody might be discharged with community-based services, a la whether it's physical therapy, occupational therapy, that people are getting under Part B. For instance, when a certified home health agency might max out, depending on what's been recommended.
Meaning, so you could always change agencies, right? And that's why I really like addressing all these items a week prior to the discharge. Because let's say you might call VNS and they're saying, oh, we're maxed out. We don't have a physical therapist. And you want to address that beforehand. Or, so for my clients, what I basically do, if I have a stroke client, I ask them specifically with somebody who has specialized training, NDT training, that can help them in the community. Sometimes they have therapists and sometimes they don't. And then it gives me the opportunity to find somebody else that would specifically meet the client's need.
Yeah, I know. There's, there's services out there. It's a very, interesting procedure. Let me put it that way. So thank you so much for all your information and everything else. We really appreciate it. Really appreciate it. So as we move on, the next aspect of what we're going to be addressing is the legal part of your preparation and what you need to know and documents, etc., which certainly have always been extremely important, or even more critical now that we are in COVID and challenging times. None more qualified to be able to share that information and to educate us than Ronald Petula. And I mentioned about passion, and once again, that thread that kind of is weaving through this whole thing. I know that, one of Ron's passion is to do creative legal planning for seniors so that they can live a more, a more dignified, stress-free existence. But that all starts, from the beginning in terms of documentation and preparation, etc. So a little bit about Ron. He is the principal of the New York-based law firm of Ronald Petula and Associates, where he practices in the areas of elder law, estate planning, Medicaid planning, trust, wills, guardianships, and estate administration. Ron serves on the executive committee of the Elder Law and Special Needs section of the New York State Bar Association, and he serves as the co-chair of the board of directors of the Long Island chapter of the Alzheimer's Association, and he also serves as executive counsel of AARP in New York. You know what? I always mention this because it's true. Ron is a trailblazer. It's a privilege to work on these webinars and also to represent his firm. And with his core values of honesty, integrity, and excellence, Ron has devoted his career to helping others understand the legal and financial challenges of aging. So welcome, Ron. We're so glad that you're here.
Well, thank you so much. What a great introduction. Boy, I appreciate that. And I really want to thank Lucille. That was absolutely amazing. Thank you so much. Very informative. And Jangir as well. That was just terrific. I think there's a lot of great information that you guys gave out. So wonderful. I do have a slide deck. So I am going to, let's see if I could share my screen here. Yeah, let's see. Okay. Can everyone see that, right? I think you can. Let's see. Okay, good. So here it is. So this is the firm, my firm. And I always say, when you're talking about discharge or the possibility of even going into a hospital, you always want to be prepared for this. You want to get your team together. You want to have it all planned in advance. You don't want to be scrambling around. You want to have everything in place. So get your attorney, your advisor, CPA. If you do need care, a geriatric care manager, a patient advocate, et cetera, et cetera. So you do want that help. Now, these are documents that individuals should have, but I want to start to talk about the discharge at this point. You know, the hospital has to provide a quote-unquote safe and appropriate discharge. Now, safe might mean home care. It might mean going to a rehab facility. You know, it depends on the situation. The Medicaid home care laws have radically changed. And I feel that I need to go into that. When you're thinking discharge, it's going to be home care for a lot of people. If not, it's going to be into a nursing home or a rehab facility. We're lucky enough to have a participant on this webinar, Phyllis Newbert, who represents Right at Home, that actually can help us all when there's a discharge or any home care whatsoever where you need companion care and it's private pay. And the firm and I have worked with Phyllis quite a bit, and she's absolutely amazing. So Phyllis, if you are listening, and I'm sure you are, I see your name on the participant list, feel free to put your information on the chat. That would be great. And I will get into Medicaid as well. So if it's not private pay and the individual is going home and we're talking about Medicaid, the rules have been radically changed. There's a window of opportunity right now to actually do planning. So we need individuals to know about that as well. But I do want to start off with the documents. And I want to start off with what I see here, the only document that I think is fine to do on your own without an attorney. It's a very important document. When you go into a facility, whether it's a hospital or a nursing home, by law, they have to give you an admissions packet. Within that admissions packet is a healthcare proxy. How many times have clients gone into the hospital having no docs? They get this admissions packet dumped in their laps, and if the individual that dumped the admissions packet in their lap, is doing the right job, they're going to, briefly explain what's in this. And then clients say, well, I start to think about who should I name to make my healthcare decisions if I can't make them, and I'm so nervous, and here I am going in for surgery, and too much pressure at the last minute. So do it beforehand. Yes, a healthcare proxy is a document where you give the right to someone else to make your healthcare decisions. It will be given to you in that admissions packet. Please don't feel like you need to sign it right then and there. Sign it in advance, have it with you, make sure the physician has it, the hospital has it. When you get out, all of your doctors have a copy of your healthcare proxy in their records, whether it's your cardiologist, your gynecologist, whoever it might be. That's really, really important. Just have that there. But now with COVID-19, we were getting calls, not quite as many right now, thank God, and I hope we don't get another surge. But what happens? Well, we don't have a healthcare proxy, and my spouse, we've had that, my parents, we've had that many times during COVID-19. In the hospital, no healthcare proxy. We listened to you, but we listened to you speak, but we didn't do the documents. Why? Sometimes people are a little superstitious. Sometimes people just tend not to move with things. So what do? Well, thank God for Dick Godfrey. He is an amazing legislator for New York State. He spent 17 years getting the Family Healthcare Decisions Act and worked on it for 17 years before the governor signed it. And what the Family Healthcare Decisions Act does says that if there's a loved one or even a close friend, someone in a hospital or in a nursing home, it has to be someone in a facility if they don't have a healthcare proxy, there is a pecking order whereby it could be a spouse, child, sibling, the list goes on all the way down to even a close friend who can make healthcare decisions for you. And that's wonderful. Not to say you shouldn't have a healthcare proxy, you should. And a blank is given to you, blank copy is given to you when you go into the hospital. But just know if you don't have one, decisions can still be made under the Family Healthcare Decisions Act. So it's very important to know, and that only affects an individual in a hospital, in a nursing home, or at home if they're on hospice. Okay, so not to say that, again, that you shouldn't have the proxy. Now, a proxy is so important because when you are discharged, you want someone else to make your healthcare decisions. If you can't make them, you need to get that in place. So part of the discharge is you got to get certain documents in place. I would say number one, because don't forget, you're coming out of a hospital, there was some medical issue. You want to make sure that you have your healthcare proxy in place, because unless you're on hospice, you won't be able to rely on the Family Healthcare Decisions Act. So think about, who do you want to name to make your healthcare decisions for you if you can't make those decisions? Think about it very, very carefully. You know, it's very interesting. I'm going through an extremely trying time now with my brother. He's in intensive care. He's been in the hospital now for almost 6 weeks. And, it's been very, very difficult just knowing what he's been through. Discharge-wise, the hospital has been all over the place with trying to discharge him quickly when he shouldn't be discharged, in my opinion. All of a sudden to have them switching gears on that when the doctor has seen him, you know, they've been all over the place. And the discharge, plan, Jangir went into it, and Lucille, that was so terrific, went into it. You want to make sure that you have clarity. And I would say that you need to speak to the social worker, the discharge planning team. And if you feel that they're right and giving you the right answers and it all makes sense, that's great. But if you don't, you may want to challenge them in a nice way, and sometimes even get someone on your side as a patient advocate to help you go through this, and as well as an attorney such as myself who could help you make sure that you have everything you need legally when you do come out of the hospital. Now you want to think also about who are you going to name on that proxy. It may not be the knee-jerk reaction of who you may think you should name. If you have a spouse, everyone would think, well, of course I'm going to name my spouse. What if that spouse would have difficulty making the decisions that you want? You may not want to be kept alive artificially if there's no chance of recovery. Well, that's what I want. But maybe your spouse won't be comfortable making that decision. You want to possibly name a child instead, or a third party who could actually follow through on the decisions that you want them to make. And don't forget that agent on the proxy has to make the decisions that you want. It's your body. How are they going to know what you want? You got to talk to them. Number one, anything that you feel you need to put in writing, put that in writing. And that's another document called the living will. That's bullet point number 4. Now, the living will is very important because you may have an individual that might be reticent to do some of the things that you want. And if you put it in writing, it's there in black and white in front of the proxy's face. They have to make those decisions, and it's good when it's in front of their face in writing, and clear. So you would want that healthcare proxy. You could do that on your own. We do it for our clients. We don't charge much at all. It's just part of a bigger package. And you may want the living will that sets forth what your healthcare wishes are. Very important as you go into the community. Now, you also want a planning power of attorney. Now, imagine you're in the hospital. You need things done. You want to name someone else who could handle everything that you need financially. Whereas the healthcare proxy is a document where you set forth someone else to make your healthcare decisions. A power of attorney, and you're going to need an expanded power, a planning power. We might add 40 to 80 additional provisions that you need to that power, and a separate statutory gifts rider to enable the agent to do the proper planning. Estate planning, planning to reduce or eliminate estate taxes, Medicaid planning. Yes, a simple power might be good enough to write checks, but you can't create a trust, modify a trust, amend a trust, tweak the plan, make gifts, disclaim assets, make tax elections, have an intent to return on. The list goes on and on. You need the elder law attorney such as myself to draft that. You want that when you come out of you want it when you go into the facility, but when you're discharged, you need that as well. Typically, an individual could be compromised, and there's going to be a lot that you can't do. Maybe you can do some things, but you may not want to. You may not have the energy to, and you're going to need help with making healthcare decisions and financial decisions. And we need to do planning. And when we need to do the planning, sometimes we need to do it quickly. And sometimes there's a window of opportunity when planning could be done and you could protect all of your assets. We happen to be in a period of time like that right now, which I'll get to in just a couple of minutes. But that's why the planning power of attorney is so important. You want a last will and testament as well. Where do your assets go when you pass away? If you're compromised physically with COVID, even if you're not compromised, we've seen too many deaths. Unfortunately, our receptionist passed away as a result of COVID. She worked for me for 18 years, and her husband as well. It was absolutely awful. Passed away from COVID-19. Get your affairs in order. It does include a last will and testament. This slide talks about the healthcare proxy, which I spoke about, and you know that you do have the Healthcare Decisions Act as a backup, but it's important that it's there. The gold standard to protect assets, whether it's for Medicaid, what if you need home care? You might need Medicaid to pay for it. Well, that's where we come in. What if you need to protect assets for estate planning purposes or estate tax purposes? That's where you need us to come in, draft a living trust to handle whatever issues you might need. Just so you know, all of these documents right now, as a result of COVID-19, again, the world has changed. The governor has given us the ability to get all of these documents notarized, and the next slide is witnessed virtually. So you could be in your living room, bedroom, anywhere, even in the hospital, and we could get the documents signed virtually if need be. Our offices are open, or I should say, a couple of our select offices are open at this time. We do have to be very, very careful. And in some of the buildings that we have offices in, the virus is still an issue, and I have not opened up those offices. So the only way to plan and pay for long-term care, well, if you have enough money, do it privately. Medicare will pay for some home care, but it won't pay for chronic long-term care. If you have long-term care insurance, and I mentioned Phyllis Newbert and Right at Home, well, long-term care insurance will pay for it, that care. And Phyllis could help you with that. But a lot of people need to look, because they don't have insurance, long-term care insurance, and they don't have enough money to pay for home care. They look to the Medicaid program. Now, the governor just presented this budget. It was signed into law in April, and it provides for a new look back for Medicaid home care. And it's a 2.5-year look back. But what we learned just last week is that the look back is not going to commence October 1. The look back is only for Medicaid applications in and submitted on or after January 1. But the October 1 date is extremely important. Why is that? Let me just get to this. Why is that? Because Medicaid has just told us, the Department of Health has just said that if there are any gifts that an individual makes or their spouse prior to October 1, which means we have to set up the trust first. We don't have much time. Set up the trust, transfer the assets, whether it's a co-op, a house, a condominium, a brokerage account, and transfer those assets into the trust. If that is done prior to October 1 of this year, there will not be a look back or a penalty period on any of those assets. So what does that mean? Let me give you an example. Okay, and here I talk about this unprecedented planning opportunity. The last time we had a planning opportunity like this, I remember, showing my age a little bit, was in August of 1993, when OBRA 93, the Omnibus Budget Reconciliation Act, was signed into law, and we were able to transfer assets in trust, and we didn't have a 5-year look back, only a couple of years. So I remember we did a couple of hundred trusts then, and when the time period ended, the window shut, we had a 5-year look back for transfers into a trust. Well, I liken this time. We have August and September. The window is going to shut. If anybody right now wants to do Medicaid planning, you got to do it now. There will be absolutely no penalty if everything is done prior to October 1. Now, it's so great to have that window of opportunity. Now, we will make these slides available because my time is going to be up in a minute. But if you're not, I guess, smart enough, or you don't need to even think about Medicaid because you're young enough, or you just don't do the planning, how do you calculate this penalty? Well, Medicaid says, well, whether it's a transfer of a home, co-op, condo, brokerage account, bank account, for every about $13,000, these are the regional rates, these numbers, for about a transfer or gift of every $13,000, there'll be a 1-month wait. So just think about it. If you live in Manhattan and you have $1 million co-op and you don't transfer that prior to October 1 and you transfer it afterwards, there's going to be years and years and years of a waiting period. If you do it now, there will be no wait for Medicaid home care. There is a 5-year look back for Medicaid nursing home care, and that has not changed. There are some gifts that Medicaid will see and say they're okay. These are called exempt transfers, such as gifts to a spouse or a disabled child, something to think about. And, and there are exempt transfers of the home, co-op, or condo. There are undue hardship laws that are coming into play that even DOH, the Department of Health, don't even know how they're going to interpret certain things. We do know, and we just got clarification last week from the Department of Health, that we can use a pooled income trust when we do our Medicaid home care, even after January 1 of 2021. So if an individual applicant has income over $895 a month, they could use their extra income to pay for their mortgage, their rent, their maintenance on their apartment, their Con Ed utility bills, the cable bills, food, etc. So we do have the ability to use the pooled income trust, but starting January, the way Medicaid will assess your ability, whether you're eligible for Medicaid home care, has radically changed. They require 3 ADLs, or activities of daily living, with physical maneuvering, and if you have a cognitive impairment, 2 ADLs. So, if you do need Medicaid soon, you may want to think about applying now, but even if you won't need it soon, get the work done now prior to October 1. So then afterwards, even if you apply for Medicaid a year from now or 2 years from now, there won't be a penalty, and they won't look and they won't see for Medicaid home care transfers made before October 1 of this year. So we have this wonderful opportunity. There is an immediate needs program for Medicaid that DOH just clarified again that they're going to make sure is there to protect individuals who may need to apply for Medicaid and need somebody in the home right away. The consumer-directed program is still alive, but they're making it quite difficult. The fiscal intermediaries are going to be reduced to, excuse me, maybe 25 people, maybe even down to five companies. The irrevocable Medicaid Asset Protection Trust is the gold standard, the best way to preserve your co-op, condo, home, brokerage account, etc. And just make sure that you have all your documents in place. You can get these slides later on. Goes over all the pros and cons of having these documents. There aren't any cons to having these documents, but the pros and cons of doing the trust. And there are very few cons to the trust, except if there might be an exempt transfer, it might be a certain exception that we can use. It's probably the only situation where the trust won't be more beneficial for someone. So that's it for me, but please take advantage of this window of opportunity that New York State has given us to plan now. So thanks so much.
So thanks, Ron. That was terrific. Great information. I have a couple of questions, but there's also a question from somebody that's that's on the call, and it pertains to the Healthcare Family Decisions Act in terms of what is the pecking order. Is there a specific pecking order that is that it goes by? How does that work?
Well, I'm happy to talk about it unless Lucille or Jangir does.
I'm sorry?
Lucille, you want to take a shot, or you want me to do it?
I think that is for you. I saw that in the chat room as well. It was during your presentation.
Yeah, no worries. So they do have a pecking order, and it is a spouse, a child or children, parents, siblings, but it does go down to best friends. If you could show that an individual is a best friend, they have to make your decisions. But if they don't know what your healthcare wishes are, then they have to act in your best interest.
So in other words, if you have a situation where, let's say you have a spouse, and let's say you have brothers, a child, brothers, sisters, all of those people would have to say, I can't do it, I can't do it, I can't do it. And Joni, who's your best friend, who knows your healthcare decision, and she's the 10th person on the list, she's the person who is then elected, or, to do that, to function in that capacity. Is that correct?
That is correct. And look at, if you don't have a good healthcare proxy, the Family Healthcare Decisions Act, won't work for you, let's say, because you're at home and you're not on hospice, and the individual can't sign any of these documents because they're incapacitated, we may have to go in for guardianship action. That's a possibility.
Okay.
So the law wanted to make sure that someone that knows you would make a decision for you, not just having a court, appoint someone.
Yeah. Good. So we want to open up for questions and discussion. We're going to unmute people, but I'm going to ask a couple of questions that I just made notations, because you hear things about wills. Does everybody need a will, Ron? Is there? Is that just a blanket thing from your perspective? Under any circumstances, you need a will.
Everyone should have a will. A will. Everyone should have a will. The attorney should draft a will. There's so many reasons why the attorney should draft a will. There's a reason for that. If you put assets in a trust, it might avoid probate, but you're not going to put everything into the trust. And you might not give everything away. It might be a diamond engagement ring. It might be certain mementos that are important to you. And my experience is that individuals just forget. They might have a bond that they totally forgot about, and the will would basically control that. But even more than that, when there's a will, if we ever have to go into court, the court always asks, what's the testamentary intent of the individual? So how did that individual want to give away his or her assets when there were two witnesses? The will was signed with all of the formalities, and it's a formal document, and the courts really look to the will for all of that. So yes, everyone should have a will. Thank you.
I'm going to throw this question out. There's a question about the Healthcare Family Decisions Act and the pecking order, and the questions asked is relevant. Is that only when a patient is, or a person is an inpatient in a facility, or or does that pertain into the home environment as well?
The Family Healthcare Decisions Act is only when you're in a facility, a hospital, or nursing home, or home on hospice. The question that I think, if you're on observation status in a hospital, which we kind of don't have at this point during COVID, right. But would that still come into play? My reading of it is that it would, even if you're in a hospital on observation status.
Gotcha. And the other question I wrote down here is that relevant to Medicaid planning. If somebody goes for Medicaid planning and they submit an application, the application gets approved. It's now, it's before October 1st, but they don't need services at that time. So is it like grandfathered in if that person needs it a year from now or 5 years from now? Is that more or less that?
It's a very good question, Vicki, because a lot of people have the misconception that we're going to do that Medicaid application before you need it. We're not. But if the planning is done, the assets are transferred before October 1, we could do that application if needed in January, in June, 2 years from now. The transfers won't show up for Medicaid as long as they're done prior to October 1. So we don't do the application in advance.
Okay, thank you. So, so with that being said, we do have, a little bit of time. Are there any questions that anybody that let me just check the chat here. I don't think anything else came through that I saw. Or any discussions or anything like that, that anybody from our, that's on the call would like to, bring forth.
Ron, I have a question for you.
Yeah.
So in regards to applying for Medicaid, you mentioned that they're looking at ADLs, and
Yes.
if you have a cognitive impairment, they only look at 2 ADLs. Now, in regards to cognition, are they looking at only executive functioning, or what happens if you have a client that has a psychological diagnosis?
Well, if the psychological diagnoses, that's part of it as well.
Okay, good.
If the individual still needs to need assistance with physical maneuvering with at least 2 ADLs, if there is a cognitive impairment. So, I mean, my understanding is it depends on the type of psychological issue the individual is having. But if that's, up to the level of a cognitive impairment, I think, that, there'd be 2 as opposed to 3. But that assessment will only commence after January 1 of 2021, not now.
Okay.
I have a question actually for you, Jangir, and Lucille. And again, I was dealing with this with my brother, but, and maybe Lucille, this is for you. So many hospitals, I know that they get paid a certain way, and the hospitals on a whole, I know sometimes try to discharge, as soon as they feel it's safe. And sometimes the family feels that it might be better for the patient to stay there a little bit longer, maybe to get stronger with, with all these professionals around. How does that work? I mean, what should a family do in that situation?
So that's a great question. And I can speak for Mount Sinai South Nassau, and I would like to project that this is the same for any other healthcare facility. We provide patient-centered care. So at the end of the day, it has to be the best thing for the patient. And if the patient's not going to be safe upon discharge, we look at, is there somebody at home? We look at every aspect of their care. And if it comes out that it's not a safe discharge, we're not going to discharge the patient. At the same time, there are things that happen, and I don't like to think that this happens often, but sometimes the hospital is meant as a babysitter. And that we also look into, it's not a place to drop off their loved one because you want to go away for the weekend. In that case, we will not be able to support that, and we would have to find a place for that patient. We do want to maintain that a hospital environment is strictly for patients in need of emergency and medical care, because that bed that you're taking could very well be used for somebody else. So, but I will tell you, yes, that happens, but it doesn't happen frequently. The majority of the time in the cases is we do an in-depth observation and assessment of the patient to make sure that we can ensure a safe discharge. Nobody wins if we don't do that, because if they were to come back within 30 days, that's a financial implication to the hospital. So trust me, we don't want that to happen.
Thank you, right. And it's very interesting on that 30-day readmission, which I think, when did that come down? It was not for, I think about 10 years ago, has it been?
Yeah, that's been in place for a while. And it also looks at the facility that the patient was discharged from. So it does, they are looking at all aspects of care and that discharge process.
Interesting, thank you.
And the physician does have to sign off saying that the patient that they're discharging is medically stable to transition to the next environment. So they have to sign off on that. So if you notice that your loved ones, for example, their O2 saturation is not constantly fluctuating, or there's constantly people moving in and they're ready to transition them to a step down subacute, that's a conversation that you should have with the provider and say, is my loved one medically stable? Are they ready to transition from a hospital to a subacute setting or into the community, or is there some concerns that I have? So even the transportation from the hospital to, let's say, a subacute setting, if your loved one is not stable, you have to factor that in, and it's a good time to have a conversation with the doctor about that and have those addressed.
Yeah,
Thank
so
you.
that's, yeah, so that, I mean, that's very great input. And I could tell you that the advocacy part of what happens, with discharge and when there are questions, and I happen to do patient advocacy, nurse advocacy work, and I also mentioned to people on the call that we are going to be having a webinar coming up in the next couple of weeks. I think it's on the 12th of August, actually, about advocacy. We have an MD. We have an insurance expert, and also Ron will speak in on that also, talking specifically about advocacy. Because sometimes, whatever it is, people don't have the time, they don't have the experience, and they really need an outside person to help them navigate through that healthcare, maze that is very frustrating and complicated, and to have those conversations. It's a very important point. Excuse me. So, so this is great work. So under new Medicaid laws, what will be the limits on home care? That question just came in.
I'm happy to answer that. We don't know under the new laws. We do know that they're going to try to limit hours with the requirement for the ADLs, activities of daily living. There's going to be a new assessment tool. Number 3, the family physician is not going to be the one who's going to get involved at all like before. There's going to be an independent physician that's going to make that assessment. If the individual is getting what they say are high hours, I'd say a 24-hour sleep in or 2 12-hour shifts, there's going to be another review to make sure so New York State says to make sure that the individual is going to be safe at home. We're going to have to see how that shapes up.
Yeah. Okay. Well, that is terrific, and we need to wrap up. I have to say to everybody on the call that if you say, oh wow, I should have asked a question, certainly we are a resource. Please have our contact information and reach out. So that's one thing. The other thing is that we certainly thank our panelists today, Lucille Used, and Jangir Sultan. Thank you so much for your being part of this, the development. A lot goes into making these things happen. It doesn't happen by divine intervention. So all your work and preparation is sincerely appreciated.
Vicki, if I
Ron,
might say something. Thank you for this, because Janier, I want to connect with you. We do a Right Transitions hospital to home program, and you would be very instrumental in that.
Oh, great. I'll reach out to you.
Yeah, that's great. And Ron, as always, thank you so much for, presenting the legal aspect of all, really what goes on, what people have to know about and educate them, accordingly. None of these things happen without a team. So thank you to Jackie Rothamel, who is on the call. And is the marketing coordinator for Ron Petula and Associates, for putting together all the information, the mechanics, the flyers, everything that she does. We sincerely appreciate it. It makes everything so much more seamless. So thank you very much.
Vicki, real quick, I wanted to make sure we mention that on August the 19th, we have another webinar with Jangir on the emergency room and the ramifications of being prepared for unexpected emergency room visits. So that's the 19th at 1 o'clock.
Right, and also on that vein, we actually have next week, we have part 2 of our, we're working with CMS, the Centers for Medicare and Medicaid Services. Frank Winter is going to be doing a webinar with us on fraud and abuse. So we have a lot of things going on, check our calendar, and, we send out information on this. But thank you to everybody. Be safe, be healthy, be well, and
everybody.
We appreciate your participation and your attendance.
Thanks.
Thank you so much.
Well.
Bye-bye. Thank you, everyone.
Thank you.